Welcome back to the deep dive. Today we are putting on our digital white gloves and magnifying glasses, because we are heading into the operating room's most critical precursor, advanced diagnostic imaging for the knee. This isn't just about spotting the obvious ACL tear, though that's important too.
Right.
We're really focused on synthesizing those subtle, high-stakes imaging nuances, a full breakdown of the synovial envelope, the intricacies of cartilage grading, and wrestling with the anatomical chaos that is the posterolateral corner.
Yeah, that's a big one.
Our discussion draws heavily on the established literature, Higazi, McClure, Morrison, and of course the essential anatomical work from Chong and Chung.
That's right. And when you're reviewing a stack of images for a patient, maybe scheduled for a scope, or a reconstruction, or even a replacement, you absolutely need diagnostic certainty.
No question.
So our mission today is explicitly to, rapidly upgrade your understanding of those subtle MRI characteristics.
Yeah.
The difference between, say, a physiologic fluid collection and an impending surgical complication. Precision in distinguishing subtle pathology from just a normal variant is absolutely non-negotiable when we're planning intervention.
Especially considering the high failure rates if you miss something, right?
Exactly. Yeah. Particularly with things like the PLC. We're really striving for that higher echelon of interpretation here.
Okay, let's start with the knee's inner lining then, the synovial envelope. We all know the mechanical basics. The outer fibrous capsule gives the structure, and the inner highly vascular synovial membrane is the dynamic workhorse, secreting, lubricating fluid, managing debris.
Sure, the basics.
But from an imaging standpoint, where does the anatomy immediately start to confuse the junior residents?
It's all about the extensions and the compartmentalization, I think. You have to remember, the synovial lining isn't just a neat single balloon. It has these crucial extensions.
Right.
Superiorly, it forms the suprapatellar recess, running deep to the quads tendon. Inferiorly, that fat pad we all call Hoffa's pad, the infrapatellar fat pad, it actually displaces the synovium posteriorly, back toward the notch. But the anatomical nuance that's really critical for understanding inflammation and fluid distribution, that involves the cruciates.
The famous anatomical misconception. Everyone thinks they're just floating in there.
Exactly. The cruciate ligaments, the ACL and PCL, they actually act like a curtain. They divide the knee into medial and lateral compartments. But here's the thing. The ligaments themselves are actually contained within an extrasynovial space.
Extrasynovial, okay.
Yeah, based on Lee's work back in '96. They're housed within the joint capsule, sure, but they're technically outside the primary synovial sac, separated by the reflection of the synovium. So if you see primary involvement of the cruciate ligaments in a disease process that you think originates in the joint fluid, like simple synovitis, you should immediately raise an eyebrow and look for secondary extension. It shouldn't directly hit the cruciates first.
So the ACL isn't truly swimming in the joint fluid, which explains why isolated synovitis doesn't immediately just dissolve the ligament unless it's something extreme like septic arthritis breaching that barrier.
Precisely. And in terms of pathology, we absolutely must focus on the blind spots. The recesses are notorious for harboring trouble.
Where things hide.
Exactly. You've got the large posterior recess, the extensions around the gastrocnemius heads, and critically, that posterolateral extension around the popliteus tendon at the popliteal hiatus. That forms the popliteus bursa. These areas, the popliteal hiatus and the posterior recess, they are classic locations for loose bodies to settle and for diffuse synovial disease like PVNS to really establish itself. A resident has got to train themselves to actively interrogate these corners on every single slice. Don't just scroll past them.
Okay, that brings us to the core diagnostic tenet regarding the synovium itself. The principle being, if you see it, it's angry.
Yeah, that's a good way to put it.
Normal synovium is the definition of a wallflower. It should be so thin it is barely perceptible on MRI.
That is the rule of thumb, absolutely, and it's a critical shortcut. Its visualization fundamentally implies pathology, whether that's acute inflammation, chronic proliferation, or, rarely, malignancy. MRI is paramount here, obviously. Power Doppler ultrasound is also great for detecting hypervascularity, but MRI gives us the precise anatomical extent.
Right.
And the immediate consequence of synovial proliferation is fluid exudation, which is why effusions are the most common initial sign of pretty much any joint pathology. But we can't just stop at fluid present. That's not enough.
No, definitely not. We have to characterize the fluid complexity. We often use the term complex or dirty fluid on T2-weighted images. Pathologically, what's actually happening to give us that cluttered, sort of dirty signal?
Well, when we call it dirty, we're seeing signal complexity that suggests more than just simple serum, right? We're seeing synovial thickening, maybe some proliferation, frequently internal sectations, or even debris, all mixed within the high signal fluid. And this is critical because a simple effusion is just a symptom, but dirty fluid suggests active proliferative disease. Assessing this requires really careful windowing on your PET-CT station. You don't want to blast the brightness and potentially mask subtle thickening within the effusion itself.
Good point.
Furthermore, if we suspect true proliferative synovitis-like, think inflammatory arthritis or PVNS, we absolutely must employ IV gadolinium contrast.
And the mechanism for using contrast here is key, right? We're looking for metabolic activity.
Exactly. Contrast helps us separate the wheat from the chaff, so to speak. Proliferative tissue, being highly vascular and metabolically active, enhances strongly and usually pretty rapidly. This lets us definitively differentiate the active, enhancing synovial tissue from the simple, non-enhancing joint effusion. Without contrast, a thick pannus of synovium can sometimes be mistaken for just high-protein fluid, leading you down the wrong diagnostic path. Contrast is indispensable when you're trying to rule out active inflammation, a mass effect, or, God forbid, an aggressive infection.
Okay, moving from the overall lining to the remnants, the plicae. These folds of vascularized synovial tissue, essentially the embryonic leftovers from when the joint cavity was forming. On MRI, they're usually these low signal intensity bands floating in the high signal joint fluid on T2 images. You can see that in figure 9.1. Which one of these structures, often just dismissed as incidental, actually becomes the primary surgical target?
The plica. Yeah, the one that generates the most clinical noise and can cause true destruction is definitely the medial patellar plica, MPP. We see the infrapatellar plica, the ligamentum mucosa most commonly. It's anterior and parallel to the ACL on sagittal images.
I see it all the time.
Yeah, and it's also always clinically silent, just an incidental finding. But the MPP, which courses obliquely from the medial wall down towards the infrapatellar fat pad, that's the source of plica syndrome.
So it's the size and its location relative to the medial femoral condyle that dictates whether it's just an anatomical curiosity or a real surgical problem. And the distinction rests heavily on that old Sakaki-Bara classification from '74.
It really does. We still use that morphologic classification to triage the significance. Type A is just a thin, cord-like elevation, functionally irrelevant. Type B is shelf-like, but it stops short of covering the anterior surface of the medial femoral condyle. These A and B types are typically incidental findings. We just document them as normal anatomy, basically.
But the moment that shelf gets aggressive and starts impinging, we're in the surgical territory of type C and D.
That's your danger zone, absolutely, and your surgical trigger. Type C is large and shelf-like, actively covering the anterior surface of the medial femoral condyle. It's set up perfectly to get pinched during flexion. Type D is basically a type C that's developed a central hole or fenestration, usually from the constant friction and wear. The mechanical pathology is simple, really. These C and D types impinge between the medial femoral condyle and the patella during knee flexion, especially in that 30 to 60 degree range.
And the analogy holds up perfectly. It's like a piece of sandpaper, right? Chronic friction against the smooth hyaline cartilage.
It is exactly that. If you see a type C or D plica on MRI, you need to look immediately for the consequences, which are demonstrated beautifully in figure 9.2. This image shows the symptomatic plica. It looks thickened, irregular, maybe fibrotic, with associated cartilage loss right at the medial patellar facet and the opposing medial femoral trochlea. This cycle friction causing inflammation, leading to fibrosis, which increases thickness, leading to even more friction. It results in progressive chondral erosion. Identifying that associated cartilage damage is the key to confirming the diagnosis of plica syndrome and distinguishing it from just, general synovitis.
Okay, let's pivot to bursae, the body's little friction pads. They're synovial-line structures meant to reduce friction between tendons, bone, or skin, usually invisible until inflammation causes fluid accumulation, giving us that classic low T1, high T2 fluid signal. Which specific bursae pathologies should we prioritize in our differential diagnosis?
We usually prioritize 3 based on mechanism. First, probably the most famous one socially, prepatellar bursitis, the classic housemaid's knee. This is almost always caused by chronic repeated trauma or kneeling. The key finding on MRI is a fluid collection that is anterior to the patella, purely in the subcutaneous soft tissues. It's outside the joint capsule entirely. You wouldn't drain this into the joint, for instance.
And the differential diagnosis has to include cellulitis here, I guess, but the MRI characteristics of the fluid simple versus complex should help triage that.
Exactly. Is it just simple fluid, or is there rim enhancement and surrounding stranding suggesting infection? The other two bursitis are more mechanically driven. The deep infrapatellar bursa is located posterior to the distal patellar tendon and anterior to the tibia. Bursitis here usually results from extensor mechanism overuse, common in jumpers or runners, causing impingement of the distal patellar tendon.
Okay.
The third is the pes anserine bursa, located posteromedially, separating the pes anserine tendons sartorius, gracilis, and semitendinosus from the medial tibial condyle.
And what's the critical anatomical distinction of the pes anserine bursa that affects how we might treat it?
The key point is that it is usually non-communicating with the joint,
Okay.
which means that if a patient has a massive joint effusion, the pes anserine bursa will likely remain dry. Conversely, if the patient presents with isolated pes anserine bursitis, you know the underlying knee joint mechanics might actually be fine. It's an isolated, localized T2 high-signal fluid collection, usually indicating a localized tendinitis or overuse syndrome affecting those pes tendons.
A critical differential point that I think gets overlooked sometimes is the obstructing plica consequence. I definitely recall seeing cases where the suprapatellar recess was hugely distended, looking like a massive effusion, but the rest of the joint looked deceptively clean.
That is a classic image trap, absolutely. Anatomically, the suprapatellar recess needs to communicate freely with the main joint space. If the suprapatellar plica fails to regress completely during development, or maybe it becomes thickened and fibrotic through trauma or inflammation, it can obstruct that communication pathway.
Like a one-way valve.
Sort of, or just a blockage. Joint fluid still accumulates, but it gets trapped, isolated within the recess. This creates a localized high-pressure system and a substantial mass effect superior to the knee joint. Figure 9.3 illustrates this perfectly. You see this isolated fluid collection ballooning out in the suprapatellar recess, like a locked room filling with water. This often requires surgical intervention just to open the channel and relieve the pressure. It can easily be confused with something like a complex suprapatellar ganglion cyst if you're not thinking about the plica.
Okay, good point. Let's move to analyzing the joint fluid itself, starting with effusion quantification. On plain film, which is often the first study, we need to recognize those subtle radiographic signs of fluid, especially on the lateral projection. Beyond just obvious soft tissue fullness, what are the reliable signs we should look for?
The signs are subtle, but they are reliable. First, the presence of a rounded soft tissue density filling the suprapatellar recess is a pretty good giveaway. Second, you look for the loss of that normal sharp fat plane posterior to the quadriceps tendon. When fluid pushes that tendon anteriorly, the posterior fat plane gets obscured or hazy. But the classic measure we still teach, based on Hall's work from '75, is the fat pad separation sign. When the infrapatellar fat pad is separated from the prefemoral fat pad by more than 10 millimeters on that lateral view, that's considered diagnostic for a pathologic effusion.
Gotcha. And given how sensitive MRI is to fluid, we obviously need an established threshold to avoid overcalling every tiny little bit of fluid as pathology, right? What's the standard measurement we use?
Yeah, for consistency and clinical relevance, Coleman and colleagues suggested a threshold back in 2004. We use an arbitrary but useful cutoff. An anteroposterior AP measurement of 10 millimeters or less in the lateral aspect of the suprapatellar pouch is generally considered physiologic, especially in an active person. Anything substantially higher than 10 millimeter requires a careful search for underlying pathology, trauma, inflammation, infection, something causing the fluid. Right, you got to find the cause. Okay, so we have fluid. Now we have to move swiftly to differentiating the fluid contents. Specifically, hemarthrosis blood in the joint. It's overwhelmingly post-trauma, but we have to keep bleeding disorders like hemophilia or even, occult tumors in the differential. In the acute setting, what's the definitive sign of blood on MRI, and what's the absolute strong indicator of an associated bony injury?
Acutely, you might see fluid layering. The heavier red blood cells sink below the lighter serum components. This layering can sometimes be visible on cross-sectional CT, too. But the gold standard sign, the absolute strong indicator of trauma-induced hemarthrosis that signals an emergency, is lipohemarthrosis. The famous fat fluid level. That's the classic teaching point, isn't it?
It is a radiographic jackpot, and its implications are absolutely crucial, as Lee pointed out back in '89. When an intra-articular fracture occurs, say a tibial plateau fracture or a supracondylar fracture, fat and bone marrow get released into the joint along with the blood. Since fat is less dense than blood or serum, It floats right to the very top, creating this distinct, unmistakable fat fluid level.
Can't miss it.
You really can't. If you see lipohumarthrosis, you have diagnosed an intra-articular fracture extending right into the joint surface. This immediately changes management and requires careful surgical planning for reduction and fixation.
And if the bleeding is chronic, say in a patient with recurrent trauma, maybe hemophilia, or a tumor bleeding intermittently, the chemical changes dramatically alter the signal characteristics over time.
That's the transition to chronic imaging findings. Chronic blood breakdown leads to hemosiderin deposition within the synovium and joint space. Hemosiderin, being paramagnetic iron, causes T2 shortening, resulting in low signal on both T1 and T2 weighted images. But the definitive sign for hemosiderin is that distinctive blooming artifact on gradient-recalled echo GRE sequences, or sometimes SWI. The iron causes local magnetic field inhomogeneities, which manifest as an expansive black signal, making the deposit look much larger than it really is. We actually exploit this artifact because it's essentially pathognomonic for iron deposition, allowing us to diagnose chronic hemarthrosis or conditions like PVNS with high confidence.
Okay, shifting gears slightly to inflammatory conditions. The literature always stresses the frustrating overlap problem. Septic arthritis, RA, psoriatic arthritis, gout. The imaging findings often look morphologically quite similar. Synovitis, effusion, maybe some erosions. How do we as imagers and surgeons help triage these conditions?
We have to rely heavily on clinical context and pattern recognition. Things like the distribution, is it monoarticular versus polyarticular? The rapidity of onset, the patient's history, and of course the laboratory results like ESR and CRP. Those are the compass. Imaging provides the map, really. It demonstrates early signs, often before plain radiographs are positive, like the extent and location of synovitis, the presence and pattern of marginal erosions, and any associated bone marrow edema, like we see in figure 9.4 for rheumatoid arthritis. But the primary takeaway for the resident, for anyone looking at these images, is this. If infection is clinically suspected, MRI is sensitive for findings suggestive of infection, but joint aspiration is the only primary means of absolutely excluding the one condition we cannot afford to miss, septic arthritis.
Get the fluid, absolutely. Focusing specifically on rheumatoid arthritis for a moment, beyond the typical diffuse uniform cartilage thinning we expect, we look for one specific MRI signature, the rice body. What exactly are those?
The rice bodies. They're interesting. These are small, usually maybe 2 to 10 millimeters long, rod-shaped or sort of cylindrical pieces of slug necrotic synovial debris. They're essentially broken off pieces of the inflamed, hypertrophied synovium, the pannus.
Okay.
Because they're necrotic tissue, not just fluid, they typically have an intermediate signal on both T1 and T2 images, which helps differentiate them from simple fluid or loose cartilage fragments. Seeing numerous rice bodies floating around should immediately trigger RA in your differential diagnosis, although they can also occur in chronic tuberculosis or other forms of chronic synovitis. It's a highly suggestive finding, though maybe not entirely exclusive, of aggressive chronic synovial disease.
Right, good to know. Okay, let's move from inflammation now into proliferation and maybe even neoplasia, the synovial zoo, as some call it. Mastering the signal characteristics here is really crucial, as the clinical presentation can be pretty nonspecific. Let's start with a classic example of an MRI diagnosis: pigmented villonodular synovitis, PVNS.
PVNS is definitely the poster child for MRI specificity in synovial disease. It's a benign but locally aggressive proliferative disorder. Typically monoarticular, most commonly affecting the knee. Somewhere between 60 to 80% of cases are in the knee. The pathology is defined by synovial hyperplasia and infiltration by multinucleate giant cells, and critically, those hemosiderin-laden macrophages.
Okay, so we revisit hemosiderin, meaning we're hunting for low signal on T2 again.
Correct, but it's the degree of low signal and using the right sequence that really clinches it. PVNS lesions are usually intermediate signal on T1, but they are dramatically low signal, high point tense on T2, and especially on gradient recalled echo, GRE sequences, because of that massive hemorrhagic load. This low signal is key because most things that proliferate and fill up a joint cavity like fluid, inflammatory tissue, even most tumors, are typically T2 bright. PVNS buck that trend significantly.
Pathologically, we sometimes call the gross appearance the shaggy red bread sign. Radiologically, this translates directly to that blooming artifact on GRE sequences, right? Like we see in figure 9.7.
It does, exactly. The paramagnetic iron from the hemosiderin creates that local field distortion that artificially expands the area of signal void. That's the blooming artifact. This combination diffuse, maybe nodular, villous synovial proliferation, shaggy look, and expensive low signal with blooming, the pigmented iron, is highly specific for PVNS. The crucial differential diagnosis here is probably chronic recurrent hemarthrosis, which can sometimes mimic diffuse PVNS because it also deposits hemosiderin. But chronic hemarthrosis usually presents with a distinct clinical history, maybe related to trauma or hemophilia, and it might be more diffuse throughout the joint, whereas PVNS tends to be more nodular or localized, although diffuse forms certainly exist.
Okay. Next up in the zoo, primary synovial chondromatosis. This is where the synovium underbays metaplasia, leading to cartilaginous nodules that might calcify into osteochondromatosis. This is one where plain film still carries immense weight, doesn't it?
Oh, absolutely. This is a perfect example of synergy between modalities. If those cartilaginous bodies have mineralized, become osteochondromatosis, the radiograph gives you the classic finding. Numerous, similarly sized, small, round bodies distributed pretty evenly throughout the joint. And crucially, the number of bodies is often far out of proportion to the degree of simple osteoarthritis you might see, like in figure 9.5. This pattern suggests a global synovial disease process rather than, say, an acute traumatic shearing injury, which would typically produce just one or two large, irregular fragments.
And on MRI, the signal appearance depends entirely on the degree of ossification, I assume.
Precisely. If the nodules are purely cartilaginous and haven't mineralized yet, they'll be intermediate to high signal on T2, similar to cartilage. But if they have completely ossified, they present as uniform low signal intensity on all sequences, basically a perfect signal void, just like cortical bone, as seen in figure 9.6. In the knee, these numerous loose bodies can cause mechanical symptoms like locking and eventually lead to secondary joint destruction, often necessitating surgical removal.
Okay, the third member of our synovial zoo is Lipoma arborescens, the fatty proliferation. Sounds distinctive.
Lipoma arborescens is a benign villous synovial proliferation where the subsynovial fat undergoes hyperplasia. It's often considered a reactive process, maybe linked to chronic mild trauma or low-grade inflammation, resulting in this fatty pseudotumor that looks kind of like a leafy tree, hence arborescens.
The imaging diagnosis here must rely entirely on signal confirmation using sequences that specifically identify fat, right?
It is entirely diagnostic via MRI, usually quite straightforward. The key is that the villous masses show signal intensity identical to subcutaneous fat on all sequences. So high signal on T1, intermediate signal on T2, and critically, they must suppress completely on fat-suppressed sequences, like SDR or chemical fat saturation. Figure 9.8 shows this typical appearance. The differential here is crucial. If you see a fatty-looking mass that enhances significantly post-gadolinium and doesn't fully suppress on fat-sat sequences, you have to start worrying about something much more serious, potentially a low-grade liposarcoma. That complete signal suppression on fat-sat confirms the benign fatty nature of Lipoma arborescens.
Got it. Fat is fat is fat. Finally, the rare but potentially catastrophic synovial hemangioma, usually affecting children or young adults, and most often found in the suprapatellar recess.
Yeah, this one requires a high index of suspicion because it's rare. It typically presents as a lobulated mass. Because it's usually a slow-flow vascular malformation, it tends to be low or intermediate signal on T1 and heterogeneously high signal on T2 due to the slow-moving blood, the venous and capillary stasis within the malformation, as shown in figure 9.9. It will enhance avidly after gadolinium administration. But the key specific feature, sometimes visible even on plain film if you look closely, is the presence of phleboliths. These are small, rounded calcifications representing calcified thrombi within the abnormal vessels. If you see an intra-articular mass, especially in a younger patient with phleboliths, you have a near certain diagnosis of hemangioma. This is important because treatment often requires highly localized resection or sometimes ablation to control recurrent hemarthrosis and pain.
And before we completely leave the masses, we should probably touch on the ubiquitous popliteal cyst, or Baker cyst.
Ah yes, the Baker cyst. Probably the most common cyst we see around the knee, shown nicely in figure 9.10. It's located posterior to the medial femoral condyle, typically nestled right between the tendons of the medial head of the gastrocnemius and the semimembranosus. They are almost always secondary to some kind of chronic joint effusion or underlying intra-articular pathology. Fluid gets pumped out through a sort of one-way valve mechanism in the posterior capsule. The key thing is that treatment of the underlying pathology, whatever is causing the effusion, is paramount. Just draining the cyst alone rarely solves the problem long-term if that joint communication remains open and the effusion persists.
Right, treat the source. And how does that differ from a ganglion cyst?
Good question. Ganglion cysts lack a true synovial lining. They're thought to arise from capsular structures or tendon sheaths, often associated with mucoid degeneration, for example, within the ACL substance itself, as in Fig 9.11. They typically show simple fluid signal, might be multilobulated, and crucially, they usually don't have that predictable communication back to the main joint space like a Baker cyst does.
Okay, clear distinction. Let's transition now to the articular surface itself, the cartilage. This is where we really demand the most from our imaging, isn't it? We need sufficient contrast between the fluid, the intermediate signal cartilage, and the subchondral bone, coupled with extremely high spatial resolution to differentiate between, say, minor surface fissuring and a whole thickness defect. The technical demands are huge because the structure is just so thin.
It is a massive challenge, no doubt. Early damage involves micro changes in the molecular matrix, things like collagen integrity, water content, proteoglycan density, often long before we see gross morphological failure, like a visible hole. Standard sequences like proton density and T2-weighted fast spin echo, FSE, with fat suppression are absolute workhorses here.
Why those specifically?
Well, they excel because they exploit the high signal of joint fluid, creating a sharp, bright boundary against the intermediate signal cartilage. And critically, using fat suppression minimizes the bright signal from Hoffa's fat pad and marrow fat, ensuring the apparent relative signal of the hyaline cartilage is maximized against the suppressed background. This really optimizes the visibility of the cartilage layer itself.
When you're triaging a potential chondral abnormality on one of these sequences, what's the sort of hierarchy of signs we teach the residents to look for?
Okay, first, you look for obvious physical failure, a defined contour defect or focal thinning compared to the adjacent healthy cartilage. That's the most straightforward sign. Second, you look for signal alteration within the cartilage matrix itself. In early low-grade chondromalacia, grade 1, the cartilage might actually look swollen and become T2 hyperintense, as shown in figure 9.3. This indicates increased free water content due to matrix disruption, even if the surface contour looks perfectly intact initially. Figs 9.14 and 9.15 also illustrate various grades.
But often, the cartilage surface looks deceptively okay, at least on first glance, and the real warning sign comes from beneath. You often mention the most important secondary sign is the underlying bone marrow edema, BME.
That is your absolute red flag, regardless of the specific etiology. BME, which shows up as increased signal, sort of hazy white in the subchondral bone on fat-suppressed images, like T2 FATSAT or SDR, is nonspecific in itself. It can be a simple bone contusion from trauma, a stress response, or related to something nearby like a meniscal root tear shifting load. However, seeing a flame-shaped or rounded focus of BME directly beneath the articular surface, like in figure 9.16, should trigger a relentless, exhaustive search for an overlying hyaline cartilage abnormality. The bone is essentially reacting because the load is no longer being transmitted smoothly and evenly through that cartilage layer. The compromise is forcing fluid and stress down into the subchondral bone. If you see focal BME in the medial femoral condyle weight-bearing zone, you absolutely must rule out a significant chondral or osteochondral defect right above it.
This naturally necessitates the use of classification systems for communication and planning. We often deal with the arthroscopic system, the radiological correlation systems, and the more detailed surgical planning systems. Let's compare Outerbridge, ICRS, and noise. How do they differ?
They all speak to the same spectrum of damage, but focus on slightly different aspects, as outlined in Table 9.1. Outerbridge is purely descriptive of the surgical view. Grade 1 is just softening or swelling. Grade 7 is fissuring less than half the depth. Grade 3 is fissuring more than half the depth. And Grade 4 is full-thickness erosion down to exposed bone. It's literally what the surgeon sees and feels with the probe during arthroscopy. The ICRS, International Cartilage Repair Society, grading is often correlated with MRI findings and relies more on depth percentage. Grade 1 is just signal change or maybe superficial fissuring. Grade 2 is a partial thickness defect involving less than 50% of the total cartilage thickness. Grade 3 is a defect involving greater than 50% of the thickness. And Grade 4 is a full thickness defect reaching the subchondral bone.
And the noise system, which seems often preferred for planning specific reconstruction techniques, gets even more granular about the state of the subchondral plate itself.
Exactly. Noise is arguably the most surgically critical, especially when deciding between something like microfracture versus an osteochondral graft or ACI. It gets really specific at the full thickness stage. Grade 3 in noise refers to full thickness defects with exposed subchondral bone. But the crucial differentiation is between Grade 3A, where the full thickness defect exposes the subchondral bone, but the cortical surface of that exposed bone is still smooth and intact, versus Grade 3B, where the exposed subchondral cortical surface shows actual cavitation, pitting, or erosion.
Why is that 3A versus 3B distinction so important?
Because that cavitation in 3B changes the structural integrity and the biological potential of the underlying bone. It significantly impacts the stability and the ability of that base to support a repair technique like microfracture or even integrate a graft properly. You often need high-resolution MRI or sometimes even CT arthrography to confidently make that 3A versus 3B distinction preoperatively. It guides the surgical strategy.
Okay, that makes sense. Beyond just grading the depth, the overall pattern of cartilage loss can also tell us a lot about the underlying etiology, right?
Yes, definitely. Osteoarthritis, OA, almost always shows thinning and focal defects like fraying, fissuring, or frank ulceration, specifically concentrated in the weight-bearing areas, such as the medial compartment or the patellofemoral joint. It's always associated with secondary signs like osteophytes, bone spurs, and subchondral cysts. And critically, we see a very strong association between rapidly accelerating OA and things like meniscal root tears or severe meniscal extrusion, which dramatically alter load distribution across the joint. Conversely, inflammatory arthritides, like rheumatoid arthritis, typically cause diffuse, uniform cartilage thinning throughout the entire joint, often including the non-weight-bearing areas as well. This uniform loss reflects the global inflammatory process where the pannus erodes the cartilage everywhere, as referenced by Verstraete et al. Focal defects are much less typical in RA, unless they're caused by highly localized pannus growth right at the margin, maybe near an erosion, like suggested in Fig 9.16.
Got it. Pattern matters. Okay, let's talk about lesions that involve both cartilage and bone, specifically when we think about instability. First, traumatic osteochondral lesions. These are acute injuries resulting from a single significant event, maybe shearing, compressive, or rotational forces causing both a chondral and a subchondral fracture.
The pathology here is straightforward mechanics. The impact forces cause a fracture through the subchondral bone, generating a combined cartilage and bone fragment, or flap. This fragment often loses its stable attachment to the parent bone. A key sign we often look for on MRI is associated cystic change. When the intra-articular pressure increases during joint motion, synovial fluid can be forcibly driven into that compromised fracture line beneath the flap, leading to bone resorption and the formation of visible subchondral cysts right at the interface. If the fragment completely detaches, it becomes a loose intra-articular body, potentially causing locking or catching, as depicted in Figure 9.8. We see this pattern commonly following acute patellar dislocations, where the medial patellar facet impacts the lateral femoral condyle, or sometimes in pivot shift injuries impacting the lateral compartment.
Then we have the specific entity historically known as osteochondritis dissecans, OCD. I know we're trying to standardize terminology now, maybe calling it an osteochondral lesion of the OCD type, but the term OCD remains really prevalent.
Yeah, OCD classically presents in younger patients, often adolescents or young adults, typically 10 to 20 years old. The etiology isn't fully understood, but is thought to involve repetitive microtrauma or vascular compromise, disrupting the blood supply to a focal area of subchondral bone, leading to osteonecrosis of that segment. The location is highly characteristic, almost pathognomonic sometimes. The lateral aspect of the medial femoral condyle, usually on the non-weight-bearing surface near the intercondylar notch. If you see a lesion in this precise location in an adolescent with knee pain, OCD is the presumptive diagnosis until proven otherwise.
And the primary goal of MRI in suspected OCD is not just detection, but crucially characterizing the stability of the lesion, right? Because a stable lesion might be managed non-operatively, especially in a young patient with open physes, whereas an unstable lesion is generally a surgical problem. We rely heavily on the Desmet criteria from 1990 for this.
Desmet's criteria are absolutely essential for surgical planning and are assessed primarily on fluid-sensitive sequences like T2-weighted fast-suppressed or STR images. We look for 4 specific signs that indicate fluid is dissecting between the osteochondral fragment and the parent bone, signaling instability. First, seen a clear linear high signal intensity, fluid signal, completely surrounding the osteochondral fragment. If you see bright fluid tracking all the way around it, it's likely detached.
Okay.
Second, observing significant cystic change interposed between the fragment and the normal underlying bone, like in Figure 9.1 time B. This implies motion and fluid ingress, meaning the fragment is unstable. Third, identifying an overlying cartilage defect or fissure that clearly communicates joint fluid down towards the fragment interface. And fourth, though less commonly done now, if an MR arthrogram is performed, demonstrating intra-articular gadolinium dissection beneath the fragment. Finding any single one of these signs strongly suggests instability and usually pushes towards surgical intervention, like fixation or possibly grafting.
And the Anderson MRI classification provides a useful structural staging framework for thinking about treatment planning, too.
Yes, the Anderson staging, often adapted for the knee, gives us a structural roadmap. shown schematically in Figure 9.20. Stage on is just bone marrow edema within the fragment area. It might be painful, but is considered structurally stable. Stage IR shows the first real sign of structural failure, the development of subchondral cystic change beneath the fragment, still potentially stable. Stage 3 is defined by fluid clearly undermining the lesion. It's completely detached from the parent bone, but it remains non-displaced. It's still sitting in its bed. This is often the stage where fixation is attempted if the fragment looks viable. The most critical surgical stage is Stage 3, where there's a completely detached and now displaced osteochondral fragment, maybe floating freely in the joint or flipped over in its crater. Stage 3 mandates aggressive intervention, either for removal of the fragment and treatment of the defect, like microfracture or grafting, or potentially fixation if the fragment is large, acute, and looks salvageable.
Okay, that's a very clear progression. Now, we've established the limits of our standard workhorse sequences like T2, FSE. They're great for morphology, but maybe can't detect that really low-grade, early matrix damage that precedes the gross morphological defects. This has spurred the development of more advanced MRI techniques focused purely on functional and biochemical assessment of the cartilage itself.
Exactly. The frontier of cartilage imaging, where a lot of research is happening, lies in this functional assessment, trying to detect the chemical changes before the structural ones become obvious. We're attempting to peer right into the health of the matrix itself.
Let's discuss a couple of the sequence modifications designed purely for enhancing contrast first. What about driven equilibrium Fourier transform, DEFT? What's the mechanism there that gives us superior contrast, particularly at the fluid cartilage interface?
DEFT is a clever sequence modification designed to manage T1 and T2 effects simultaneously to boost signal from certain tissues. It uses a specific 90-degree radiofrequency pulse right at the end of the sequence repetition to efficiently flip the longitudinal magnetization back towards equilibrium along the z-axis.
And why does that matter for cartilage imaging?
Well, tissues with very long T1 relaxation times, like synovial fluid, get effectively enhanced by this technique. The result is hyper-intense, very bright synovial fluid right up against the intermediate signal cartilage. This dramatically improves the visibility and delineation of the cartilage boundaries, especially that crucial interface between the fluid and the cartilage surface. It's really an acquisition method focused on maximizing boundary clarity, which helps in spotting subtle surface irregularities.
Okay. Then we have balanced steady-state free precession, SSFP sequences, known by various vendor names like True FSSP, Fiesta, or BFFE. These are often used for high-resolution 3D acquisitions. What's special about them?
SSFP sequences are fantastic for cartilage because they use rapid switching between radiofrequency excitation pulses and refocusing gradients to reach a steady state where both T1 and T2 contrast contribute heavily to the final image signal. They provide an excellent signal-to-noise ratio and a relatively short scan time, which allows us to acquire high-resolution 3D volumetric datasets of the whole joint. Like DFT, synovial fluid is typically hyperintense, and the tissue contrast between cartilage, bone, ligaments, and fluid is generally excellent. This allows us to map the full 3D surface continuity of the cartilage, looking for defects in any plane, which is invaluable for detailed preoperative planning, especially for complex repairs or replacements.
All right, now for the techniques that actually try to measure matrix health itself, starting with T2 relaxation time mapping, how does this technique go beyond just simple visual assessment of signal intensity?
T2 mapping moves us into the realm of quantitative biochemical assessment. The basic principle is that the T2 relaxation time of water within a tissue is directly related to the freedom of movement and the binding characteristics of those water molecules within their microenvironment. In healthy cartilage, water is relatively restricted, tightly bound within the highly organized collagen proteoglycan matrix. When that matrix starts to break down, maybe the collagen network gets disrupted or proteoglycans are lost, the water becomes less restricted, more mobile. This increased water mobility leads to an increase in the measured T2 relaxation time.
So essentially, we're detecting loose or less bound water as a sign of matrix damage.
Exactly. Operationally, we acquire images at multiple different echo times, TSE, and then use software to calculate the T2 relaxation value for every single voxel in the cartilage, generating a quantitative map. We usually display this map using color coding or grayscale, where higher T2 values, representing more mobile water, indicate areas of matrix damage or degeneration, This allows us potentially to detect subtle degeneration, maybe due to chronic abnormal loading or early post-traumatic changes, often months or even years before any visible thinning or fissuring would be apparent on our standard morphological T2 FSE sequences.
And perhaps the most cutting-edge tool currently, delayed gadolinium-enhanced MRI of cartilage, DGEG-MRS. This seems like functional imaging at its finest, aiming to directly map glycosaminoglycan GEG content. We probably need to go into a bit more depth on the physics here, as this really points towards the future of cartilage prognostication.
DG-MRX is arguably one of the most elegant applications of MRI physics in orthopedics, I think. The fundamental concept relies on charge interactions, specifically charge repulsion. The contrast agent we typically use, gadolinium DTPA, carries a negative ionic charge. Glycosaminoglycans, GAGs, which are these large, essential structural molecules within the cartilage matrix that give it its compressive stiffness and resilience, also carry a very high density of fixed negative charges.
Okay, so negative repels negative, like charges repel.
Precisely. In healthy cartilage, the high density of negatively charged GAGs effectively repels the negatively charged gadolinium contrast agent, significantly hindering its penetration into the matrix. Therefore, after COD-D administration and a delay period for equilibration, usually around 90 to 120 minutes, the concentration of gadolinium within healthy cartilage remains relatively low.
Now, what happens in damaged cartilage where those crucial GAGs have been depleted?
Well, in damaged or degenerated cartilage, the GAGs is broken down and leached out of the matrix. This reduces the overall negative charge density within that area of cartilage. Without that strong charge repulsion barrier, the negatively charged gadolinium contrast agent can now diffuse much more readily into the GAG-depleted matrix. High gadolinium concentration causes significant T1 relaxation time shortening. So after the delay, we then perform T1 mapping, acquiring data to calculate the P1 relaxation time for every voxel. A low T1 value on the resulting calculated map indicates a high gadolinium concentration, which in turn acts as a direct quantitative proxy for depleted GAG content in that specific region of cartilage.
Essentially, the contrast distribution tells us exactly where the foundational biochemical resilience of the cartilage matrix has been compromised.
It does. It allows us to map true biochemical damage, not just structural failure. Clinically, this has revolutionary potential because we can quantify the health of the matrix and potentially influence surgical decisions much earlier or more precisely. For instance, if you see a small structural cartilage lesion, but the surrounding cartilage shows significant GAG depletion on a DGM-BRIC map, you might predict that the prognosis for a simple repair like microfracture is poor, perhaps pushing you towards a more robust strategy like ACI or osteochondral grafting that brings in healthier tissue. This moves us entirely beyond just grading structural defects into a realm of predictive functional assessment.
Fascinating stuff. Okay, let's conclude with the knee's most complex and, historically at least, most misunderstood region, the posterolateral corner, or PLC. The diagnostic gap here has been enormous, and the clinical consequences of missing a PLC injury are, frankly, devastating for patients.
The statistics really are a severe indictment of historical orthopedic practice and imaging sensitivity. Recent data from acute trauma studies show significant PLC injuries in up to 21% of cases, and associated iliotibial band injuries in up to 58% of acute knee traumas. These figures vastly exceed the historical estimates of maybe 6% or even less for the PLC. We were simply not looking hard enough or maybe not recognizing the signs adequately.
And the key clinical takeaway for the resident, the most important association, is the relationship between the PLC and the cruciate ligaments, isn't it?
It is the ultimate clinical takeaway, absolutely. PLC injuries are rarely isolated. They are overwhelmingly associated with ACL injuries and frequently with PCL injuries as well. If you, as the surgeon, reconstruct the ACL but fail to diagnose and concurrently treat a significant PLC deficiency, you essentially guarantee persistent rotational instability, particularly varus and external rotation instability. This leads directly to cruciate ligament graft failure in a depressingly high number of cases, as LaPrade and others have shown, reference 45. The PLC acts as the primary restraint to external rotation and varus stress, especially near extension. Without it, the ACL graft is doomed to experience excessive load and eventual failure. It just can't handle those combined forces alone.
A major contributing factor to this historical negligence and misdiagnoses has been the sheer anatomical confusion, the anarchy in nomenclature, as you called it earlier.
Complete anarchy is not an overstatement. LaPrade's systematic review of literally 250 years of anatomical literature lays bare the chaos, focusing specifically on the term arcuate ligament. That single term was used synonymously by different historical authors to describe no less than 3 distinct structures. Sometimes the popliteofibular ligament, sometimes the fabulofibular ligament, if a fabella was present, or sometimes the capsular arm of the short head of the biceps femoris, references 2650.
That explains why residents get so confused. They read older papers or textbooks, and the terminology is completely ambiguous. They don't know what structure is actually being referred to.
Precisely. It's like trying to build a complex machine where half the critical parts are just labeled the thingamajig. For decades, surgeons and radiologists often didn't know for sure if they were discussing repairing a specific ligament or just a thickened part of the capsule when using that term. The modern consensus, driven by meticulous anatomical dissections and confirmed by high-resolution MRI, is quite clear. The term arcuate ligament should probably be dropped entirely from routine clinical description. It is not a single, distinct, definable structure. It's merely an arched appearance formed by the convergence of multiple individual static and dynamic stabilizers in that region. We must describe the individual components we see, particularly the lateral collateral ligament, LCL, the popliteus tendon, the popliteofibular ligament, PFL, and maybe the fabulofibular ligament, FFL, if present.
Okay, so focusing on those key individual components, let's talk about the specific MRI appearance of injury to the critical static stabilizers. What are we looking for in an acute PLC tear?
The most critical static structures providing stability in the PLC are the lateral collateral ligament, LCL, running from the lateral femoral epicondyle down to the fibular head, and the popliteofibular ligament, PFL. An acute tear of the LCL typically appears as discontinuity of the ligament, maybe increased T2 signal within its substance, or waviness and laxity on coronal or axial images. It's often associated with injury to the lateral capsule as well. But the PFL is arguably the real powerhouse for controlling external rotation stability, acting synergistically with the popliteus tendon. It runs through the musculotendinous junction of the popliteus obliquely down and back to attach onto the fibular head.
And what's a typical mechanism or pattern of injury we see involving the PFL?
While mid-substance tears can happen, the most common and often most devastating injury pattern involving the PFL is an avulsion fracture or ligamentous avulsion right off its insertion site on the fibular head. On axial and coronal images, you're looking for bone marrow edema and surrounding soft tissue edema right at the fibular styloid, often with the PFL ligamentous fibers or even a small bone fragment visibly lifted off the bone or retracted superiorly and medially. Missing a PFL avulsion injury, which ideally needs acute repair or reattachment back to the fibula, is one of the fastest ways to leave the knee functionally unstable, particularly to rotation. So the rule is, if you see significant injury signs around the fibular head on MRI, you absolutely must assume PLC involvement until proven otherwise and meticulously evaluate all the individual structures.
This ongoing need for anatomical standardization and precise terminology, as you mentioned, extends even to relatively recent years with the sort of rediscovery and naming of structures like the anterolateral ligament, like AOL to LL.
It absolutely underscores that knee anatomy is not a closed book, not by a long shot. The AL, now increasingly recognized as an important secondary stabilizer, particularly to internal rotation, especially during flexion, highlights the continuous refinement required in our anatomical understanding and surgical approaches. For consistent surgical success, the diagnostic mission for the PLC must move entirely past historical ambiguity and embrace universally accepted individual structural terminology. This ensures that every necessary component of the complex stability system back there is assessed accurately on the MRI and, if needed, addressed appropriately during surgery. The MRI must serve as a high-fidelity surgical roadmap, and that requires us, as interpreters, to have accurate source anatomical knowledge and use precise language.
Absolutely. Okay, that was a really deep and, I think, essential dive into the nuanced imaging of the knee's synovium, cartilage, and that tricky posterolateral corner. We started with the synovium, reinforcing that fundamental rule. Just visualizing it clearly on MRI is often the first sign of pathology. We established that conditions like PVNS have that telltale low T2 and GRE signal because of the hemosiderin, where the blooming artifact is really your signature finding. And we contrasted that against lipoma arborescens, which should follow fat signal perfectly and suppress completely on fat-sat sequences, like in figure 9.8.
We definitely covered the plica problem, emphasizing that it's really the Sakakibara type C and D medial patellar plicae that are the true mechanical culprits, the ones that act like sandpaper, leading to that associated cartilage destruction on medial femoral trochlea and patella, shown well in figure 9.2. And in fluid analysis, always look for lipohemarthrosis, that unmistakable fat fluid level, which is the absolute diagnostic slam dunk for an acute intra-articular fracture extending right into the marrow space.
Right. For cartilage, we define the hierarchy of grading systems, noting the critical surgical distinction in the noise system between grade 3A, where the exposed subchondral cortex is intact, and grade 3B, where there's actual cavitation or pitting of that cortex, which significantly guides decisions between microfracture versus maybe grafting procedures.
And that crucial secondary sign, never ignore a focal, flame-shaped focus of bone marrow edema right under the cartilage. It's the bone's way of screaming that there's likely an overlying hyaline cartilage defect causing abnormal load transmission. You have to find that cartilage lesion.
Finally, we stress the critical importance and the historical underappreciation of the posterolateral corner. PLC injuries are far more prevalent than once assumed, especially in multi-ligament injuries, and their overwhelming association with ACL graft failure necessitates accurate imaging identification of injury to individual structures, particularly things like the pulpatofibular ligament, often involving avulsion from the fibula, and we need to abandon confusing, outdated nomenclature like the arcuate ligament.
Absolutely. Precise anatomical description is key there.
We also touched on those advanced techniques like T2 mapping and the real power of DG MRI, which uses those principles of charge repulsion to actually quantify glycosaminoglycan depletion mapping, the true underlying biochemical breakdown of the cartilage matrix, potentially long before gross structural failure becomes visible on standard sequences.
And this emerging functional assessment capability, I think, fundamentally challenges our traditional model of orthopedics, which has historically focused, maybe necessarily, on fixing or replacing structures after they demonstrably fail. So the final thought for you, the listener, is this. Given our evolving ability, particularly via techniques like DG to potentially predict cartilage failure years before a patient ever experiences significant pain or develops a visible structural defect on a standard MRI, what will that technological capability eventually do to our current definition of orthopedic surgery? Will we soon transition from focusing primarily on repair and replacement towards a future of true, predictive, maybe even prophylactic orthopedics, intervening to rebuild or protect the matrix based on a quantitative biochemical map, rather than waiting for a physical defect to appear? That is the question you should perhaps consider the next time you're reviewing a preoperative knee MRI.